Let's discuss electrophysiology. In the superior portion, you will see the Sinoatrial Node, pictured here. The SA node is also called the pacemaker of the heart, and of course it controls the heart rate. It produces an intrinsic rate of 60 to 100 beats per minute. The SA node also communicates with the left atrium via the sinoatrial pathways. This allows both the atria to contract almost simultaneously. There is a slight delay between right and left atrial impulses. This delay ranges from 40 to 70 milliseconds per impulse. Anything less than 60 beats per minute is considered bradycardia. Conversely, rates greater than 100 beats per minute are defined as tachycardia. Whether rapid or slow, the rate is driven by the SA node. The SA node communicates with the atrioventricular node, or AV node. This impulse travels from the SA node to the floor of the right atrium, where the AV node lies. The AV node conducts this electrical message to depolarize the remaining myocardium. The bundle of His. This impulse continues to travel downward through an anatomical structure termed the bundle of His. This structure is located at the superior portion of the septum. The impulse is then transmitted to bundles which branch laterally on either side of the septum. They separate to form the left and the right bundle branches. These impulses are responsible for depolarizing both the left and right ventricles, respectively. And finally, the Purkinje fibers. As the fibers extend toward the distal and inferior portions of the ventricle, the fibers decrease in size to microscopic measurements, called Purkinje fibers. Innervation of every myocardial cell occurs as the impulse travels this path. Let's discuss causes of abnormal conduction. One is enhanced automaticity. This is simply a spontaneous depolarization of cardiac cells, like escape pacemaker sites that increase firing rates. Examples of this include atrial fibrillation or flutter, supraventricular tachycardia, premature atrial or ventricular complexes, VTAC or VFib. Another is reentry. This is where part of the electrical impulse is actually blocked, causing a delay in part of the impulse. The delayed portion of the impulse reaches the recent depolarized cell and stimulates it during relative refractory, causing tachyarrhythmias. Examples include these: supraventricular tachycardia, ventricular tachycardia, PVCs or PACs. Another cause of abnormal conduction is escape rhythms. This occurs when an SA node slows or fails, or an AV junction or ventricle takes over. Examples include junctional or ventricular escape rhythms. Additionally, conduction disturbances are considered AV conduction is too slow, and this may be a result of trauma, drugs, MI, or electrolytes. Examples certainly include atrioventricular blocks. Let's review some fundamental principles of coronary circulation. Firstly, myocardial perfusion. Remember, myocardial perfusion only occurs during the ventricular diastole phase of the cardiac cycle. No perfusion occurs during systole. Myocardial perfusion also is affected by heart rate and blood pressure. You know this by the formula of cardiac output equals heart rate times stroke volume. So tachycardia, or increased heart rate, decreases filling time and perfusion and also increases oxygen demand. Bradycardia, or slow heart rates, provide slow filling and also decrease perfusion. In cases and events of hypotension, there is of course decreased perfusion through the coronary circulation. Let's discuss cardiac cell properties. The term refractoriness is the extent to which cell is able to respond to a stimulus. During the absolute refractory period, cardiac cells do not have the ability to conduct electrical impulses despite the strength of any electrical stimulus. Finally, there is a relative refractory period. This is a vulnerable period where electrical stimulus can stimulate the cardiac cells, leading to an undesirable outcome.